তুষার ভাই শুরু করেন।
আমরা কি স্টার্ট
হ্যাঁ
করতে পারি?
ইয়েস।
কামরুল, আমরা কি স্টার্ট করতে পারি?
জি তুষার ভাই শুরু করেন।
Okay. Assalamu alaikum and good evening, respected physicians. After a long break, we're again starting our program organized by ECG Study Group. And today is our 57th lecture. This will be given by our respected Professor Rafiq Ahmed sir. And as usual, before starting up the lecture session, I request Professor Abdul sir to say some words regarding our Rafiq Ahmed sir and the program. Wadud sir.
Assalamu alaikum. Good evening to everybody. It has been a long break, but I think that break was very futile because Bangladesh didn't do anything good in the cricket field. Well, the past is past. Let's proceed further. Today, we are going to have a lecture from Dr. Rafiq Ahmed sir. We all know that we call him our mentor. Do you know why? A mentor is somebody who makes you advance in study, in your skill, and in your thinking process. He can change you. The purpose of education is to change. If one can achieve that, that person should be accepted as a true mentor because he can bring the change. Dr. Rafiq is like that. I won't say anything more. Thank you, Rafiq sir, for being with us, guiding us. Let us enjoy Dr. Rafiq sir's lecture.
Good evening, everybody. Well, we had a break, but probably the cricket was not as exciting. I mean, it was exciting, but not as expected, right, or as we wanted. But that's good. So we're going to go back after a long break, and it takes time to catch up, and I hope more and more people will go back into our regular session, and more and more people will participate in it. So, I mean, what I'm going to do, my job is, there are many good speakers, and then I summarize it and do things that to reevaluate how we are doing. So we'll start with this one. We'll please look at it for a few seconds, probably 20 seconds, and then we will give a poll. And I would expect, please, all of you should answer, or as whether right or wrong, but please answer with a little bit of thinking process, not just random. Yeah, okay, there's a choice. Let's click one of those. That doesn't add to the learning.
So is it for 20 seconds?
Yeah.
Okay.
Okay. Well, I think that's good, right? rotation, and he said first 1 week, you go along the ward, look at the eye, and look at the diagnosis. And he gave us, after 7 days he started teaching, and what he did is he taught us how to do visual diagnosis. This is actually a visual diagnosis. If you look at this ECG, except for slow heartbeat, this is a normal ECG. And this is actually, if you increase the rate, that will be the 90% of ECG in our clinical practice, because 90% of ECG that we are going to do are going to be normal. So yes, sinus bradycardia because rate is low, otherwise it's a normal ECG. And that should be the final report, but in the process we will also do the PR interval, QRS duration, QT interval, QRS axis. 2 to 1 AV block. Yes, I know why whoever answered 2 to 1 AV block is a good answer, but the question is rate is 45. And if you look at lead V2, you may something which looks like a P wave, but it is not in other places, because if you do a 2 to 1, so I'm going to measure in lead 2 here, 1, 2, 3, 4, 5, 6 big boxes. I should have seen a clear P wave after 3 boxes, and there is none. So it is not 2 to 1. But whenever you see a heart rate of 40 to 45, please always keep that in mind. So thank you. What do any comment on that or anything?
Sir, actually, you have always told us, look at lots and lots of ECG and make an impression what a normal ECG looks like. And first impression is always comes out to be quite a good impression, and most of the time correct.
That's what the next ECG.
Sometimes our audience wonders why you think this is very nearly normal ECGs. Actually, that's the most important thing that you are trying to develop a habit of looking and having an impression of normal ECG.
Exactly. So what happens every time I see an abnormal ECG, in my mind, there should be a comparison. And the comparison is
নিউট্রাকে ডিস্টার্ব করতেছে কেন আজকে
কিছু আগে নিয়ে এলো ঠাটা করছে ওটার উপর সন্ধ্যা দিকে খাই গেছিল ওটার উপর ঠাটা করছে তারপর ঠিক করছে কে তুমি বাতাটা না এই করতেছি দেখো এই দেখো কোন কোন বলতেছে এদিকে কি আছে এদিকে
এই তাড়াতাড়ি বটম দে
বাবার মডেল দে মডেল নেই এত
Recording in progress. Poll দিচ্ছি স্যার।
For 10 seconds, because we have a long look at.
ওকে স্যার, স্যার ইন্টারনেটে একটু প্রবলেম করছিল তো স্টার্ট করেছি স্যার।
তুমি 10 সেকেন্ড পরে এখন বন্ধ করে দাও, 10 সেকেন্ড পরে হলে হবে, সবাই দেখেছে এটা।
So, because what I have done here, I always like simple things, but here I have made it a little bit tricky because all the answers are actually correct answers. And the question is, what is the most, and I think Wadud is the best person to comment on this.
Sir, I was giving the to look at the questions, because if you want to talk about about sinus arrhythmia, he need to have a long rhythm stream. We don't have it here. We don't have it here. All the answers which held the term sinus arrhythmia must be default. This one. Number two, look at the one sinus rhythm with sinus arrhythmia is to be normal ECG. And when you want to have that, you have to have a group of R interval low heart picture. There's not present here like that. In R interval, there is a difference. There is very little P sinus arrhythmia. That's what Sarah was saying.
So, I mean, all the answers, but look at it, that initially it looks very regular. But if you look at the last one, it's 1, 2, 3, 4, 5 boxes. The one before is, so there is a subtle variation. You don't, if you say, sinus rhythm normally ECG. So the question is between number 3 and number 4. Is it abnormal ECG because of the T inverse? Is it normal? But that's a normal accepted variation that you can normally see. And so that's what I was trying to point out.
That can point,
I have
sir.
a portion, sir. That is a
Yes.
by physics
Yes.
way. But that but in
The
same
the
lead,
Antodhi.
in lead 2, lead 1, there is no much variation
Yes.
in the P wave.
Yes.
The P wave are similar. So whether it's an artifact,
This is the one that you
before that, so P
hear,
wave
right?
on the same in the lead 2 and lead 1, P wave are not that is no variation. Similar P wave.
Yeah.
Why the different P waves in position?
This one, right?
Right.
Yes. So the interesting part is that sinus beat. Please remember one thing: there can be certain, because sinus node is a 1-inch long structure. Depending on which part it is coming from, you can see a certain degree of variation. But as long as that doesn't change overall, because if the sinus beat is exiting from the top of the sinus node and the bottom of the sinus, there is a difference of 1 inch, and that's why we can see some degree of variation in the P wave.
Sir, can I make
And
a
of course,
comment? Go
go ahead.
About the T wave,
Yes.
T inversion can be present normally in AVR in lead 3 and V1. If they are isolated, there is no contiguous lead changes. These do not count as pathological.
Yes. So of all these answers, I will take all the first 3. So and in that respect, we're very successful. Number 4, the finding is correct, but the comment is wrong. It is not an abnormal ECG, right? We all agree on that, right, Dr. Shafiq? Yes. Yes. So this is not an abnormal ECG. The findings are all correct. ইয়াং আমার জন্য বুঝছো মানে আমি কালকে দেখলাম এক মহিলা 89 year old দেখলে ওকে তুমি 65-70 so I'm glad nobody answered number 1. That's fantastic. Number 2 is correct and number 3 is also correct. Because it is true, sinus rhythm with right bundle point block, but little bit more correct is if you look at the PR interval, it is long. So it's first degree AV block. So whoever answered, it's a question of not only, I think whoever answered the sinus rhythm with right bundle, this is our normal tendency. When we look at a picture, we always like to look at the prominent abnormal finding. And in the process, sometimes we miss minor abnormal findings. Those are also important. So please pay attention to it. But I think I'm very, very happy that all of us are, majority of the participants are answering, not missing the major findings and also answering them. These are, even though this is abnormal ECG, but this is a common, it's a normal abnormal ECG. That's the way I define it. It's the right bundle branch. It's a very common finding. So thank you.
Sir, whether we can say right axis deviation, that is trifascicular block as well?
Yes.
Yes, I ignored that part on purpose, but actually it is extreme right axis. So the question would be, should I have added left posterior fascicular block?
Yes.
Because of the extreme, yes. So yes, that term can be used because of the really axis deviation. Thank you. The thing about multiple choice question is the questions are never made randomly. It is also important for us as a teacher to learn how to create multiple choice questions. That means all the choices should be partially correct.
Yes.
We cannot randomly put a very, very wrong answer, wrong choice. And the answer will be the most correct answer, will be the right choice.
Remove both them. Interesting.
So when the time is over, I think, is the time over?
जी सर रिजल्ट शो इज पब्लिश करा
Shall we discuss this?
Yes, sir.
Okay, Dr. Shafiq?
Right, sir. Actually, I just want to go with the poll because it is definitely right axis deviation, no doubt about it. And left atrial enlargement evidenced by V1, there is the downstream is more than the upstream, and also and that is definitely in V5, V6, V4 there is almost Q wave, just a little wave in the V4 and V5, but V6 is clean cut Q wave, and as well as in the inferiors there is Q wave. So more likely it is, and there is also first degree block as well. PR interval is prolonged. So I just go with 3. That is first degree block, left atrial enlargement, and or anterolateral infrared.
Would there any comment?
Sir, sir, AVR.
Make a comment.
4-star and no dialogue in here.
Tushar, do you want to make a comment?
Sir, in AVR, the QRS is positive.
Right.
Freedom, you guys. It's just a sprinkle of more on top of that.
Yes.
In Discord,
And That's the most important thing about if the AVR is that much positive, you have to think about there must be some sort of vesicular block. Otherwise, it's impossible to have a positive wave like that. And which way has it gone? Has it gone to the left way, leftward extreme deviation, or the rightward extreme deviation? If it is leftward extreme deviation, AVL must be positive. If it is the rightward extreme deviation, then the AVL will be negative.
Which one? What did you say?
When we get this, AVR is that much positive,
yes,
usually we have a vesicular block associated with that. Otherwise, you do not get extreme deviation like this.
Yes. So the question is this left anterofascicular block or posterior fascicular?
Sir, that's what I was saying. If it is the left way extreme deviation, the AVL will be also positive. If it is the right-sided extreme deviation, AVL will be negative.
So AVL is positive here.
Yeah. So it's left anterofascicular block.
So I thought, the question is whether there is an inferior MI or not.
Yes.
To have MI, you have to have a Q wave. If you look at lead 3 and AVF, there is a small R wave, tiny.
Small R wave, right, sir?
Yes. So that's why, initially I had the choice in the number 4, inferior MI, I took that off. And I felt, if you all agree, that is sinus rhythm, there is first degree AV block, I did not put that part here, but left atrial enlargement is there, left anterofascicular and full anterolateral MI. And I think that probably is the most reasonable answer, right?
Yeah.
Any comment?
Sometimes people get confused whether, particularly in case of inferior MI, if you have vesicular block, be careful about commenting about inferior MI.
Exactly. And the other part, what do I get confused still? When somebody has left bundle bind block.
Yes.
You can have that pattern, which is very difficult to say whether it's inferior MI or it's because of this left bundle bind block. So those are the situations that we are. So I think answer-wise, I thought that probably the last one is the most accurate, but I will also take number 3.
Number 3.
Because
I will take these two, sir.
Yes, I'll take both of those. But please keep in mind, one question is, sometimes with left anterofascicular block, before committing on inferior MI, please be careful whether there is a small R wave or not. The same confusion happens when somebody has left. But the other one that can be confused at inferior MI is WPW syndrome.
Yes, sir.
In that case, the PR is the giveaway. All right, so we'll go to the next one. So this is a patient on telemetry monitor, came with history of syncope, and this is what the patient did. Is somebody keeping time? How much? I think most people have answered the question. 18 people answered, and the choice answer has been 5 people said sinus rhythm followed by sinus arrest. And then majority said 12 said atrial fibrillation followed by atrial standstill, then junction skip it, and the few said, one said atrial fibrillation will pause. Is Mohsin on the line or?
Mohsin, are you here? Mohsin Hussain?
It is 3. Atrial fibrillation.
Sadi bhai, are you here?
Sadi kothay? Sadi ache?
Sadi bhai achen to.
Might not be active.
Okay. So shall I talk or you want to talk?
So this is relation with atrial standstill. then junction escape beat.
Fantastic. So,
Please go ahead.
yeah, but a few people say, I always like to give benefit to the 5% thought that this was sinus rhythm followed by an sinus arrest. Yes, it looks like a pointer is, you can see the pointer, QRS, maybe P wave, but look at overall, there is no pattern. Other lead, there is no definite P wave. So yes, some the fib may look like P wave. It happens as the rate gets faster in some leads, but irregular RR interval, no definite P wave. And then I'm going to bring number 4. If it happened that it was the atrial fibrillation with a pause, when I'm seeing all this fibrillator wave and there's nothing there, so that means when this line was happening, not only in one lead, in both leads, that means in this point there is no AFib at all. So that means the most diagnosis is atrial followed by atrial standstill. That means the atrial fibrillation stopped, and then it came back with a junctional escape beat, with a ventricular, and then junctional beat. I'm sure the sinus beat came back, and that's how a lot of times happen. Yeah.
Sir, one question has been, Dr. Abunai Mahmud Hassan, he is asking, what's the difference between sinus arrest, sinus pause, and atrial standstill?
Okay, so sinus arrest will be that if I have sinus rhythm and then I have a long pause which is not multiple of the P to P interval. So if it happens that I find an interval which is 2 times the sinus beat, I'll call it 2 to 1 SA block. If it is 5 times, I'll call it 5 to 1 SA block. But if it doesn't match with the pause, with this, then it will be sinus arrest. But here, I am not starting with sinus at all. I'm just starting with an atrial fibrillation. So I cannot apply that. In that case, the most likely term to use will be atrial. That means atrium is not contracting at all. Then I have a junction beat.
I think for the audience, it's important that the atrial standstill actually, the term is coined particularly in these cases of atrial fibrillation. When there is a chaotic rhythm and then there is nothing, no electrical activity.
Yes. All right.
Sir, the question now, do you have to put a pacemaker in this patient? What are the criteria when you have atrial fibrillation with atrial standstill?
So this patient came with history of syncope.
So we have to put it.
Then now it's very clear on the telemetry monitor. Kind of patient, they go back and forth between. When they convert to sinus rhythm, they'll be fine, and then they will go back into AFib again. And every time they will convert, they'll have a pause, and that's when the pacemaker will be needed. And then I will probably put a pacemaker and then start antiarrhythmic treatment to maintain sinus rhythm.
But if a patient has, sir, atrial fibrillation and atrial standstill, but no history of syncope, what will you do?
Oh, so it depends what time and what was the patient doing and what was the symptom. A lot of times I will do Holter monitors and we will find 6, 7, 8 second pause at night in patients and no symptom at all. We will not put a pacemaker in.
Yes.
Unless we have daytime pause, but even on daytime pause, you have to ask the patient where they're sleeping during daytime, because some people sleep at night at around 3, 4 o'clock, and obesity. So it's very symptom related. Thank you. So this is a patient, that 86-year-old male who presented with syncope, history of ischemic cardiomyopathy, LV ejection fraction 25 to 30%, history of pole later on. Don't put the pole yet. This is not. Just take the pole away.
Remove pole to top.
Oh, no, the pole is not there. Fine. So hypertension paroxysm atrial fibrillation. This is the first ECG of the patient, and this is all the ECG you will see. There will be date and time. So if you look at this was on 28 July at 5:26 p.m. when the patient came to the hospital. So I'm glad that majority of the people who are present today are answering the questions, which is good. Please do answer and we'll discuss and we'll give credit to everybody. 14%. Motion নাই না?
মহসিন তুমি কি আছো ভাই?
ঠিক আছে।
রফিক ভাই নাম্বার 2টাকে একটু অ্যাড্রেস করেন যে তিনজন বলছে ভেন্ট্রিকুলার ট্যাকিকার্ডিয়া।
Yes. So হাফিজ তখন তো আরামে ছিলাম, হাফিজ চুপচাপ আছে। এখন আমাকে I have to be careful now. So the whole point what Hafiz is trying to point out, is it tachycardia? Tachycardia is a rate over 100. It is not. So whatever it is, you take that part away. So it is not, it can be any tachycardia. It is not a tachycardia at all. So that number 2 is out of question. And I'm glad that nobody called it sinus rhythm. So now we are left to two choices, junctional rhythm with right bundle branch block and accelerated idioventricular rhythm. And I will give credit to both persons. What goes against idioventricular rhythm is the V1 morphology. That's the only one. First R is bigger than the second R. If I did not know the ECG subsequently, I will take both answers as correct answer. But please remember, when you have initial R bigger than the second R, it is most likely right bundle type. But then, even though I am saying that, it is not fulfilling the criteria in lead 1 or lead V6. So I will take both answers as correct answer. Now, this same patient, after a little bit later, this is the ECG at 8:20 p.m. after 3 hours. Now, what will you call this one? And then after looking at this, when I look back at the other one, then it will make more sense of what it is.
ভ্যালু এডিশন হয়েছে। রিভু পোজ দাও।
Their Apple phone. A blind date with a fanboy. Sign me up. He's literally is blind. He has blindfold on. All right.
নেটে বোধহয় কিছু প্রবলেম হচ্ছে। ইন্টারনেট কানেকশন
recreated from Blade Runner 2049 involves walking through a rainy city. There's a massive corporation ball with a nice little advertisement.
Kariye at the background. Okay.
Sir, good.
Good. So at least Hafiz's question took away one thing, ventricular tachycardia. Nobody said it's ventricular tachycardia. So question is it junctional rhythm or accelerated idioventricular rhythm? Now, if you look at this in the rhythm strip V1, there is a P wave. There is something which looks like P wave. I always say that. But it is present before each QRS complex. And it is initial positive followed by negative. So that means it's a sinus P wave. So it's sinus rhythm. And there is first degree epilogue I did not mention. Again, left anterior fascicular block. There is now probably a small R. I added the inferior MI. It's again debatable. But definitely loss of R wave in the anterolateral leads. So that is probably an old anterolateral myocardial infarction. So I'm going to put both at the same time. Now look at this. You see, this is when it was junctional rhythm, V1
exactly same, and V6 similar, and lead 1 is similar. So, but this ECG, the first one, I mean, it's tough to, if somebody says accelerated ventricular rhythm, I'll take it. If it says junctional rhythm with left bundle, right bundle with left ventricular block. Somebody raised hand, Dr. Khan. Muntasir Abid Khan.
রিভু মুনতাসিরকে একটু করতে দাও।
জি স্যার।
So, please, even though I did not mention about the first degree endurance, this patient also has first degree AV block.
Yes.
So, by definition, it's trifascicular block.
That actually gives clue why the patient is having multiple episodes of syncope.
Is Dr. Muntazir Khan coming?
রিভু
স্যার উনাকে পারমিট করা হয়েছে বাট উনি ওখান থেকে আনমিউট হচ্ছেন না।
Okay, so ঠিক আছে, তাহলে আমরা same patient. The ECG before was 28 July, and this is 29 July now. Next day. I have put the heart rate is 53.
Yeah, Rafiq bhai, technically, left anterior hemiblock are old inferior. আপনি তো একই সঙ্গে রাখবেন না।
It is, yes. It is difficult. I mean, that's a problem because inferior MI can cause left axis deviation. We talked about that. You were absent in that, but this can be a big problem.
ওই আমাদের এখানে ওই যে বোর্ডে এক্সামিনেশন সময় হয় যে কোনো একটা মানে টিক দিতে বলে।
Yes, yes, you were right. Absolutely. Absolutely. Okay, so we have 10 answers, and majority said junctional rhythm, left bundle, old anterolateral and inferior myocardial infarction. Then junctional rhythm, left bundle one block. Some said sinus rhythm. So sinus rhythm, to be sinus rhythm, there should be a P wave, but there is no P wave before any of these KRS complexes. And I struggled with this. Ahmed may make comment whether I should call it a left bundle branch block or non-specific interventricular conduction lead, because lead 1 fulfills the criteria of left bundle. But look at these leads. They don't as much, right? But it is possible that if we go a little bit, like sometimes if you go to V7, V8, you will see that pattern. So whatever it is, if there is left-sided block and there is ROA progression is lost, so it's anterolateral and then probably inferior MI. But as Hafiz said, but the whole point is this patient presented with the junctional rhythm with the right bundle, left anterofascicular, trifascicular block, next day developed this block and junctional. So question is, what, and then this is the older ECG a year ago, and similar to the last ECG, except that this is sinus rhythm with left bundle, or I'm not going to fall on this one. Question is, what is the most likely etiology of syncope? Remember, this patient came with 86, ischemic cardiomyopathy, ejection fraction 25 to 30%, and presents with syncope. And these are all possibilities. So what we are talking about, you can answer anything you want to, whatever you think reasonable. This patient could have had any of those. But I want to see what everybody's thinking process is in this diagnosis.
কিন্তু আমার একটা কথা হলো রফিক ভাই যে এই ঘটনা যদি শুক্রবার দিন মানে আমি এখানকার হিসেবে বলতেছি যে even Friday afternoon nobody is around still you need to put a temporary wire.
Yes.
Yeah, that well, now we're going to come to that. So you make that comment here because Friday is better to do it
রোগীকে জানে মাইরো না.
Yeah, whether you do it Friday or Saturday, it is better to do it Friday. So what will be the diagnosis? Let's give the poll.
The important thing you have to consider is the age, the ejection fraction, the presentation, and the ECG findings. Review poll though.
আর এই ইসিজি গুলা দেখার সময় এই আমি ফেলোদরে দেখছি এত ইমোশনাল হয়ে যায় ইসিজি দেখতে দেখতে পেশেন্ট ভুলে যায় পেশেন্টের এক্সামিনেশনই কেউ করে না.
Yes. So more people answered. Majority said intermittent complete heart block. This patient presented with one episode of syncope, and I'm sure all the panelists will agree that this most likely causes intermittent complete heart block, right?
Right, sir.
Yeah.
Yes. Right. But we also need to keep in mind if this patient had multiple syncope, I will more or less rule out VT. But VT is also a possibility. Sixth sinus syndrome is a possibility because the patient goes from sinus to junctional. Vasovagal is unlikely. I mean, it's an option, but I think in this setting, because the problem is, if I consider vasovagal in a patient who is a high-risk patient, then I am just ignoring the patient in a way.
Yeah.
So I think we all agree as a group that intermittent complete heart block with the primary diagnosis, sixth sinus syndrome, and ventricular tachycardia are the considerations. Question is, what to do with this patient? Now, if I want to prove VT or no VT, I can do electrophysiology study. Problem is, if his electrophysiology study is positive, it supports the diagnosis. Negative does not totally rule out VT, especially in the presence of ischemic cardiomyopathy. Now, these are the choices that I am giving that what we are going to do to this patient.
Yes.
কিন্তু আপনি ইএফ দেবেন না echo information available না.
Oh, this is the EF 25 to 30%.
Oh, okay.
And primary diagnosis is ischemic cardiomyopathy.
Patient carries the diagnosis of ischemic cardiomyopathy.
Okay. Good choices, Rafiq bhai. Patient dementia নাই.
No dementia. No, these are
কোনো ক্যান্সার নাই.
No cancer, no dementia. They're fairly fit. I mean, by any standard, fit 86-year-old male.
Audience, for the audience, I'm saying that the question Hafiz Bhai is asking, because these are the points we have to consider for deciding about the treatment. Sir will be talking about that. Guidelines are very specific about these things.
Okay, the poll, please.
আমরা বাংলাদেশের এখানেও যে futility of care if a patient is very important when we providing highly expensive device therapy.
So, absolutely. So, I think the management wise, we first have to ask what Hafiz asked the questions. One, is the patient demented? What is the overall condition of the patient? Is there any need for fit? If those are not present, which was not present in this patient, I think 3 last choices are the choices that we have to accept.
Right.
Depending on what the patient wants. If we accept the diagnosis intermittent complete heart block, and if the patient wants everything to be done, and if the patient has symptom of heart failure, then biventricular defibrillator is the best choice for this patient. Second will be, we can go for a single chamber defibrillator implantation. Third will be philosophical question. If I personally cross 85 years of age, if I ever do that, then I'll probably want just a pacemaker. I can say, look, don't do anything to me, pacemaker. Then I may want a choice of whether it's a biventricular pacemaker or a single or dual chamber. That will be a different thing. But so that's how the decision should be made. For biventricular defibrillator implantation, you must give choice to the patient. If somebody is young, I always say, look, if you take a defibrillator, if you do not take a defibrillator, that's a stupid choice. If somebody has crossed the age of probably 75 in Bangladesh and 80 over 80 in the United States, I always give them choice. Look, this is my recommendation. I will accept whatever you choose. Wadud or Hafiz or Shafiq, any comment?
ভাই আমি একটা জিনিস বলবো যে আমি এই আমাদের জুনিয়র ডাক্তারকে বলি যে অনেক সময় they see that patient had a pacemaker and they make arrogant comment, oh, the cardiologist did not know. But you need to talk to the cardiologist before you criticize somebody, that it is a discussion between the physician and the patient, that the cardiologist may be aware, as Rafiq bhai pointed out. Ideally, the best choice is by VICD, but it's not that ignorance. Sometimes the situation and the patient preferences, and for Bangladesh is even more important, for immediate threat is from the bradycardia complete heart block. So you can give a pacemaker and then give supportive care. It's not the ideal, but it will salvage the situation for now. So it is important to overall address before pointing out somebody is ignorant or make arrogant comment. We need to be very humble and see the overall situation.
Right.
Shafiq or other than any comment?
So really, I'm agreed. Actually, patient need to be salvaged first. But considering the patient's pocket, it is wise to put a pacemaker first, even in the single chamber. That is important for the salvage of the patient, because if we think it is intermittent complete heart block, so that is why. But definitely, biventricular ICD is the best choice for the patient if patient.
Yeah, perfect. Thank you. So, I mean, what we are all saying, please remember this, that look at the clinical scenario of the patient. Symptom relief. Please remember 2 things. One, even with ICD, people will die. And even without ICD, 70% of patients will survive more than 3 years.
Right, sir.
Please keep that in mind. So you have to be, this is a very, very philosophical decision about giving a defibrillator. Like personally, I would rather die of VF than die of terminal heart failure, because I will not know. I'll know it for a few seconds. And that's my personal view. And I discuss that clearly with my patients. How do you want to die?
Right.
And it's important. Thank you. So the next patient.
Synchronization will be helpful, and the ICD will prevent arrhythmic death. But
yes,
from the patient perspective, death is death. Is it ischemic cardiomyopathy? Overall, survival will be longer with the defibrillator and by VICD. But the question is how the patient wants it in terms of patient's choices and financial situation.
You know, personally, I feel if I am 70 plus year old, you give me a choice between a biventricular defibrillator and biventricular pacemaker, I'll probably choose biventricular pacemaker. That significantly improves quality of life.
Right.
And so, and with significant risk reduction.
এটা আপনি ভাবির পরে ছেড়ে দেন, কারণ তখনও যদি আপনি মাছ মারতে যান আর মাথা ঠিক থাকে তাহলে সবকিছু করা ঠিক আছে। আর যদি আপনি বেড রিডেন হন খোদা না কাস্তা আর ডিমেন্টেড, তখন আমি বলবো যে রফিক ভাই
Yes, yes, that's true. So, I mean, medicine at one point becomes a philosophical discussion, and that should be a compassionate philosophical discussion with the patient. And it is very, very important that we sit down with the patient and treat them as if they're our family member, which they are actually.
না, এটা আজকে ঘোষণা দিব, নেক্সট ডেটে আপনাকে দেখাবো।
Okay.
আজকে
So
ঘোষণা
this is a female, 41-year-old female, had 3 days of nausea and vomiting and presents with dizziness. And this is the first ECG. It's a little ugly looking ECG, but please look, in every ugly picture there is something good. So please start with that good part and then go back forward, and you will understand this ECG.
আর রুগীর এই ব্যাকগ্রাউন্ডটা কি ছিল?
41-year-old female, 3 days of nausea and vomiting and episodic dizziness.
এইটাই।
Everybody is answering very nice.
That's a clue.
Yes. Okay. So
Sir, I think,
majority said
sir, your program is successful, sir. Because this is the
with PVC bigeminy and prolonged QT. The way, this ECG looks ugly, but start with the middle part. Look, you can see the sinus. And it is not tachycardia. It's more than 3 boxes. P, QRS, P, QRS, P, QRS. And then if I go back, I can see the PVC bigeminy. And when it is sinus, the QT is more than half of the RR interval. That's the giveaway. It's a long QT. So the question is, so this patient, this is at what time? Its time is written in the bottom, and later on does this. Please look at this ECG, and then we'll give the choices. So any multiple choice question, the picture should tell you what the answer should be. Then you look for the answer in that. We sometimes look at questions and then try to find the answer. The picture or the context of the question should tell you what you are looking for. So these are my choices now. If you could give us the poll. Give a poll, please. So this is great, right?
Sir, yes, people are actually learning very well.
Yes. So torsade, why torsade?
How many people answered actually? How many people answered?
13 people, 13 out of 13 answered correct.
Oh,
very last time 17 people answered. But first of all, white QRS tachycardia, but it's this one QRS is looking down and this one is looking up, it stops, and it's preceded by long QT and long short sequence. So this is clearly torsade, no question about it. Question is, what are you going to do with this patient? Okay, so majority said number 3. 4% said start amiodarone and check electrolytes. Any comment from Fadud, Hafiz, or Dr. Shafiq? Fadud, you are
unmute yourself.
You have mentioned in the background the patient has nausea and vomiting for 3 days, so there must be electrolyte disturbance related to the prolonged QT interval. So first choice is we should look at the electrolytes, and the treatment wise for torsa, intravenous magnesium is the choice.
Yes. So the reason amiodarone is we have a reflex for amiodarone. Anytime we see white fluorescence, we want to start amiodarone. Please remember, amiodarone prolongs QT. And if somebody has long QT from electrolyte disturbance, it will make it worse.
Yes, yes, yes.
So, and if this patient had background bradycardia, I would have tried to increase it. But this patient doesn't have background bradycardia. This patient actually has close to sinus tachycardia. So let's check, give magnesium. This patient's potassium was 2 when this happened. And so this is next day.
Sir, can I make a comment?
Yes.
In Dhaka Medical College, we sometimes get patients from ICD-derby who have had diarrhea and then later develop the prolonged QT and torsa.
Yes.
They send the patient to us.
Yeah.
We have had multiple patients in the last few years.
Yes. So, America, look at this. This patient came yesterday at 3 p.m. and 4 a.m. potassium is still 2.1. They give potassium, but they don't do that aggressive potassium replacement. So you have to be aggressive about replacing potassium in this patient. And by that time, still the EKG is, QT is prolonged, and they're probably a TU complex, but P wave. And then subsequently, when the potassium gets normal, look at this QT intervals are still long. It will, because there is a lag between potassium level and exercise. There is potassium was 4.3. It is getting better. And then by 1st of October, you see, potassium is 4.2. The QT has totally normalized. So please remember, even
magnesium on this side, magnesium
actually, yeah, they get magnesium, but the thing was that magnesium, the magnesium even without checking, that is the standard protocol, and we all do that, right? Yes. So, and then you can see that there is evidence of left atrial enlargement. So those are 2 cases. What time is it now?
Sir, we got 10 minutes more at least.
We'll do some random ECGs now. 2 cases, and so let's look at this one.
আপনি অনেকটা লিনিয়েন্ট, কিন্তু আমি বলি যে ওই টর্সার পেশেন্টের যদি কেউ অ্যামিওডারন দেয়, ইটস এ ক্লিয়ার ফেল টু মি। It's not compromising. It is so bad to give amio.
Absolutely, because in the setting of long QT, and especially torsade, it can be disastrous actually.
Yeah. Maybe next time, sometime, I'll show some cases when Rafiq Bhai is here about few cases of polymorphic BT.
Great, that'll be good. So I think we have a good. Nobody said atrial fibrillation. That's good news. And then we have a fair distribution between all 3 other choices. So to call sinus, we need a P wave, sinus P wave, which will be upright in lead 1 AVL, 2-3 AVF, biphasic in lead V1. We don't have that. Question then, is it junctional rhythm or ectopic atrial rhythm? When I quickly looked at it, I thought maybe it's a junction rhythm, but there is something before the QRS complex. Here there is an artifact, but here it is. And I have magnified that. I have magnified this too. You see, you can see the P wave. But that P wave is negative in lead 2. So it's an ectopic atrial bradycardia. I don't remember the context of this patient. I'm sure most of these patients are from one of my hospitals. This is 88 years, most probably presented with syncope. And if there is history of syncope with ectopic atrial bradycardia, this is very much consistent with 6 sinus syndrome. So please keep an eye on it. So I'll take junctional or ectopic atrial, but the diagnosis is actually ectopic atrial bradycardia.
I'm actually impressed, Rafiq, by the answer pattern. Apni khayal korchen kina is way better than before.
Of course,
yes,
no.
Yes.
This is
I'm
very impressed. I'm
really,
very happy.
Really happy.
Yes.
আপনার আগের ইসিজিতে টি ওয়েভ গুলা কিছু বললেন না?
No, I just wanted to keep it a little. Give me 1 second. Actually, the same patient. This is the ECG of the same patient. The poll, please.
Remove poll down.
You see, the problem in this kind of ECG, you have to decide where you want to start. Are you going to start before the pause or after the pause? That's a decision that I always grapple with. And that's how you decide on the diagnosis of this patient. I don't.
রিভু পোজ দিচ্ছ? রিভু আর হিয়ার উইথ আস? আজকে নেটওয়ার্ক স্যার এত খারাপ হয়ে গেছে ইদানিং।
রিভু ওদের নেটওয়ার্কে পড়ে গেছে।
স্যার
তাহলে কি আজকে এখানে
রিভু পোল
জি স্যার দিচ্ছি।
Okay, the poll is here.
Very good.
Okay. 21 people answered. Shall I discuss this?
Yes.
Okay. So the choice is 3 people answered sinus rhythm with atrial premature beat. So if I consider that, then if I start from here, this is the initial beat followed by a premature beat, but there is nothing before that. So this is not a sinus beat with a premature beat. Let's go to lead V1, these 2 beats. P wave biphasic in lead V1, biphasic. So basically, there is sinus rhythm and degree of sinus arrhythmia. So these are sinus beats. And this is a sinus beat followed by bradycardia, the junctional escape beat. So sinus bradycardia, junctional escape beat, right bundle. This is not a junctional rhythm. To be junctional rhythm, all of them have to be junctional. It is not. It is not an ectopic atrial rhythm because when we have P wave, they are fulfilling the requirement of sinus beat. Even though I have only V1 and V1 to go with, because in lead 1, 2, by that time, there is actually lead 1, there is a positive, lead 2 is positive, and lead AVL is positive. So whenever there is a sinus P wave, it conforms to, so it is sinus bradycardia with junctional escape beat. And this patient, he had ectopic atrial bradycardia. Now this is clearly consistent with sinus syndrome. And this is the patient ECG year before, clear-cut sinus rhythm. I don't want to go over this. I think we should stop here, right? We had enough for today.
Yes, sir. But we really enjoyed it.
Thank you.
I hope the audience also enjoyed the show.
There are a couple of people who raised hand. Do anybody want to talk or make any comment? So we find out if there is anybody who wants to.
Sir, I just want to go, sir, previous ECG, sir.
Okay. This one?
No, sir. Previous one. Yes, sir. This is the discussion point. Next one, sir. Just you have discussed the ECG.
Yeah.
Right.
Yeah,
Yes, sir. Right here, sir. If you look into the V1, first beat, second beat, third beat is the sinus.
Yes.
Next beat is the ectopic.
Escape beat. Yes.
That is escape beat, sir. Sinus. And this beat, next beat, is it sinus or ectopic?
It is sinus, because you are right. I mean, Dr. Rafiq has a very sharp eye, because but it is a positive negative.
Yeah.
So
positive negative, but still peer interval is there is a big difference.
Yeah.
Yeah. Oh yeah. Yeah. You're right. So I think I should have mentioned this. What happened? There's a P wave, but this beat is the junctional beat.
Yeah.
Right.
So this is too close to call it a sinus.
So
this is junctional.
Yes. So the sinus conducted. Sinus, before it could conduct, there is a junctional escape beat.
Right.
Absolutely. Okay.
This patient has significant conduction system disease.
That is difficult to say, Hafiz, because when there is a P wave, it conducts. But this one is because of the because of the because of the
right bundle left axis.
Yeah. Yes, definitely, and there's no question about it.
Right bundle block, left anterofascicular block, both are there.
Yeah.
But the AV conduction we don't know. Thank you. Anybody any comment? Otherwise, please.
Sir, I have a announcement. In the next class, in addition to our usual ECG presentation, Dr. Mokaddam Sadi Bhai will present a little bit about history of cardiology and the great discoveries that have been made over the centuries. That will be around 15 to 20 minutes presentation. I hope we'll be enjoying that too.
So are you going to do that before or after?
I think we'll start with that, sir, and then we'll go.
Yes, exactly. That'll be great. Thank you.
It will be add a little bit of spice into our usual presentation.
Rafiq sir, I have a question, sir.
Yeah.
Sir, in the previous ECG, you mentioned that the sinus beat that is not being conducted because the junction beat, the simultaneous junctional beat appears.
Yes.
Sir, what is the physiological PR interval that lowest possible PR interval that countable as sinus conduction?
No. This beat that Dr. Shafiq mentioned,
yes,
this
sir.
could be a normal PR interval. But in this patient, because look at the PR interval.
Yes, sir.
No, you can get normal PR interval. Yeah, short PR, but by definition is 120 milliseconds will be around normal. So this is not, if I had just this QRS complex, you gave me this, there is no way for me to tell that this is a sinus beat with a junctional escape. It is, yes, we are talking about it just in this context because all the PR intervals are totally different, and this probably simultaneously happening sinus beat with a junctional escape.
So probably if the PR interval is less than 110, then we should not say it is a conducted sinus beat.
No. That is not true.
Is that a possibility?
Okay. So the question is, the suggestion is if the PR interval is less than 110 millisecond, we should not call it a conducted beat. That is not true. We will define it as a short PR interval. But we cannot make any more comment. And if it is consistently short PR, that means the driver is the P wave. If the short PR is because they are independent, then there will be a variation in the PR interval. If the PR is constant. Now, of course, if there is a short PR and you find there is a negative P wave in 2-3 AVF, then of course it's a retrograde P wave. But junction, let's keep it, junctional beat with retrograde. But there is a constant relationship between the two.
So let me clarify, Rafiq. Can I clarify one thing?
Yes.
So the differential of short PR interval is either pre-excitation or Lown-Ganong-Levin, or the ectopic atrial rhythm, or junctional. In this context, most likely junctional is the cause for this, because it also need the situation. Here, by looking at one beat, we cannot call that this is pre-excitation, because it has to be in the context of the overall.
Exactly. But also some people, you will find young people with short PR intervals. And the mechanism they're talking about, some people have small AV node, some people have atrio-nodal or atrio-Hessian bypass tract without obvious pre-excitation pattern. And these are all electrophysiological diagnoses have to be made.
Thank you, sir.
And young people can have high vagal tone with sinus and alternating junctional rhythm.
Yep, absolutely.
So it all comes down to the basic question, the scenario, whether the patient is symptomatic or not, the age and the other features, it is ECG features. Here you are saying that the patient have extensive conduction defect because the patient have tachycardia, etc.
Yeah. All right. Good. Thank you all.
Thank you, everybody. We really enjoyed today's session. Arun, are you here? Long time no see.
Arun sir was here, sir. Arun sir is here, but as he mentioned, there are some problems in internet in Nepal sometimes. So,
like us.
Yes.
I would have liked to have some comments from him. Ajam, are you here?
Sir, sir.
Bolo bhai, your comments, please.
Sir.
Your comments, please.
স্যার আমার কমেন্ট স্যার হচ্ছে যে প্রোগ্রামটা স্যার কন্টেন্ট কিসের ব্যাপারে বলতে হবে স্যার?
এমনি তোমার এনিথিং।
আমার কথা হচ্ছে
শুনলেই তো ভালো লাগে, শোনো।
না স্যার, প্রোগ্রামটা কন্টিনিউ করতে হবে স্যার, এটা হচ্ছে আমার একটা চাওয়া, কারণ হচ্ছে এটা একটা রেগুলার প্র্যাকটিস থাকা উচিত। আমি এটা চাইবো স্যার যাতে এটা কন্টিনিউশনটা থাকে আর কি স্যার। এটা আমার একটা মানে রিকোয়েস্ট আর কি স্যার।
ইনশাআল্লাহ।
তোমরা মাঝে মধ্যে কি আমাদের কি বাইরের সঙ্গে কানেকশন স্টপ হয়েছে না এখনো শুনতে পাচ্ছি
স্যার? না, আজকে আসলে ইন্টারনেট খুবই খারাপ, খুবই বাজে। বেশ কয়েকবার আমি আউট হয়ে গেছি, আবার ঢুকতে পারছি, আবার আউট হচ্ছে, এরকম হচ্ছে আর কি।
No, I mean, if you, for the audience, I mean, this is, I'm learning from this. We are all learning. You have to see that between faculty, we have difference in opinion. And sometimes I don't see something that Dr. Shafiq, Wadud, or Sadi or Hafiz looks at it and sees. So that's the whole point, that medicine, we are never complete or perfect. We share information with each other and learn from each other. And we keep doing it all along our life.
Rafiq sir, I have some clarification. The longer and living syndrome, short period, now it is called enhanced epidural contraction in young people. So is it true? Because then?
Yes, because that was the diagnosis. Because that's why I'm saying that short PR doesn't always mean a pathological condition.
Yes.
Absolutely.
Yes. Thank you, sir.
Thanks, everybody. And Rafiq sir, as ever, thank you so much.
Welcome.
And we really enjoyed. After a long gap, we are actually looking for this program again and again. And the audience, thanks to everyone who has joined us. And in the next program, Sadi Bhai will be waiting for your presentation.
Yeah. Okay, bye.
Ribhu and your team.
Yes, sir.
Thank you, Kamru. Thank you, Bhai.
Thank you, sir.
Thank you.
Assalamu alaikum.
Thank you, sir. Assalamu alaikum. Good night, sir.